Okay. So good morning, everybody. Thank you for joining us again for Monty Hardcat Conference. And we have, again, some really good friends who join us from Bordeaux, Prof. Modene and Dr. Bonnet, who are going to be talking to us about combo procedures. But also, Thomas, you have to, you always talk about innovation and you have to tell us what the Atlantic Valve Academy is. I'm learning all these new things here. So, as part of your introduction, tell us a little bit more also about the program in Bordeaux since you moved there and how things are changing and what the Atlantic Valve Academy is, please.
Okay, so Azim, thank you. I wanted really to say that we are super happy, and personally, I'm very proud to join this Montefiore live demos and discussions. You also set the basis of a very ambitious program, and we are thankful for this. So my name is Thomas Modene. I'm a professor of cardiac surgery, but I adopted very early the interventional techniques. And as Azim has been saying, I'm an innovation lover. So when I came to Bordeaux 2 years ago, I brought with me all this innovation interest, and I integrated a group which have been really working in a hard team atmosphere already. And we combined the cardiac surgery, the echocardiography, and the interventional cardiology department in order to make it one team. It's really one team. So we all belong to the same service, to the same unit, with the same people. Our nurses are in common, our present is in common, and our future is in common. So that's very important to highlight. We created this Atlantic Valve Academy because there is no innovation if there is no adoption. So we are, on the west coast of France, and we wanted to make, the west coast actually from Rennes, Bordeaux, and Toulouse is the most active and innovative part of France today in this particular field. So we created this foundation to be more integrative and to be open also to the other part of the Atlantic, which is where you are, Azim.
Right.
So based on this AVA, we are looking really forward to creating much more collaborations and exchanges without borders, because I think, we are lucky, you and me and some other colleagues here, to be involved in many programs, but it's not the case of our colleagues. And the beauty of it, this very well, is that we can share. So this is the idea behind AVA. And to be honest with you, this perfect combination, communication, technical skills, and the large basin of population in Bordeaux. So the Aquitaine region where we live is 6 million inhabitants. So it drains a lot of patients. And that was the key of success of my integration here in Bordeaux, and why I think one of the reasons we're here with you today, Azim. I hope that it's okay.
Yeah, no, that's phenomenal. I think, you really, I don't think all my colleagues here in the US know how innovative you are. But for those of you who don't, Dr. Prof. Modene, Tamar has been one of the first surgeons really to push the boundaries for doing transcatheter therapies. He was I remember the first time I met you. You don't remember, Thomas. You were talking about transcarotid, doing TAVRs, transcarotid 10 years ago, over 10 years ago. Everybody thought you were nuts, right? And now in the US, that's become in many centers the preferred alternate access approach. Okay, and you were the first to do it, but you've also done so many other things. First transcatheter mitral valve replacements, new devices. So, you really are innovating in this field. And so we're very lucky to count you amongst our friends here at Montefiore, who we can rely on, and hopefully we can collaborate more in the future.
I hope so. That's why Guillaume is going to work with you and Juan at CRF.
Oh, fantastic. We're looking forward to having you, Guillaume.
So he will be continuing what already Augustin and Sebastian have started. Azim, honestly, coming from you, it is a great acknowledgement, and I'm very proud of it, honestly. All these things are are good, but the most important thing is to get the how do you say, the acknowledgement of big key opinion leader like you. Thank you very much for this.
No, you are. We all respect you very much, my friend. Okay, let's get on with it. Teach us something about combo procedures.
Yeah, so I think Azim, as everything, we it's not because we want to be step ahead, but I think my double culture as surgeon tells me how much is important to move forward. I mean, now almost anyone can do TAVR, like me. MitraClip is also becoming very standardized, but they are a part of our indications in surgery, which are not captured by the evolution of the percutaneous treatments. And innovation is not only adopting the new device, innovation is also heading into new chapters of our treatments. And combo cases are one of these. So combo cases we're gonna try to give, I mean, we have a couple of slides to open the discussion, set the basis of the talk. We're gonna show you a couple of videos that we recorded for this topic. And so innovation is also pushing the boundaries beyond what we're doing today. So why combo cases? Because it's a surgical-like approach. Many patients that could have a TAVI today are referred for surgery because they need probably a tricuspid annuloplasty, or they need a mitral repair or mitral replacement. But so this is more than anecdotic, it's more than being marginal. So this is the first justification. Double valve surgical interventions also are associated with higher perioperative mortality. So that means if we believe that less invasive, thanks to percutaneous techniques, is a chance for the patient, we have to be able now to recommend, suggest, and prove that double valve replacement or treatment percutaneously is obviously a good thing. The third point is that it's what I call in-out treatment. So that means the patient come with a disease, he leaves without a disease, and you restore the valve disease that he has been coming to see you for. There are many combinations. Mitral and tricuspid, I think this is the most frequent one. Mitral and aortic, I think it's also frequent and underestimated. We still do a lot of these patients in surgery, even in elderly patients. And this will lead surgically to longer operations, longer cardiopulmonary bypass and clamping, which could explain also why there is a higher mortality. And of course, aortic plus tricuspid, because we know that tricuspid in patients who have aortic stenosis is how do you say, a bad prognosis factor. So I try to put in this slide what it's pro and what is against having this combo approach. What is in favor of this combo approach for me is all in one. Again, as I've said, you don't take, or the patient doesn't take the risk of having a valvular or heart decompensation because of the left valve disease that you couldn't treat or you didn't want to treat. It's an optimal treatment strategy like surgery. It could generate more economy to the hospitals and the public health system, providing it is compensated correctly. And I think by eliminating all the disease for which the patient is coming to see you, you would offer better quality of life. And the patient is taking one-time risk rather than one risk, one general anesthesia, and then going back and forth, infection, length of stay, all these things. I think this is what I believe are in favor. What is against is this could be long procedures. Also, although I will show you that in the cases we did with the skills that we could develop in a team, this can make these procedures much more easier to adopt. It needs some skills. So that means if you are good in TAVI, you have to be also good in other percutaneous treatments. And some of them, like in mitral replacements or tricuspid, are just in the beginning of the journey. But we have to lead this and show this. The natural history of improvement, what I mean in this is that some of the valve disease, mitral or tricuspid, could recover after the TAVR treatment, for example. So we have to learn a bit more about that. If you combine the treatments you need to access, if you put two access in the same time, that means you have two risks in the same time. In some type of therapies, it would be, or could it be any interaction between mitral and aortic? For example, if we do a transcatheter mitral valve replacement with high radial force, would it interfere with the TAVR? For example, objectively, we've seen a patient in whom we did a TAVR with the remaining paravalvular leak. When we implanted a tendine, for example, it ended up without any paravalvular leak. So this even was a chance. We didn't imagine this. And logistically, the room configuration, I mean, the C-arm is not positioned the same way if you do a mitral clip or you do a TAVR, and vice versa. So these are some of the things that we have to discuss. And of course, more importantly, lack of reports and data. I mean, there's only small series coming from big centers, and with desperate, I mean, how do you say, differences in the patients who were included. So we looked at the evidences and we made a kind of resume of what we read here and there. I mean, this is not a literature review, but we know that there are studies suggesting an increase of early mortality after TAVR in patients who have significant mitral regurgitation at baseline. The problem is, in the different reports we've read, mitral regurgitation definitions where patients have been treated were different from a study to another. And many of the studies were underpowered. And actually, they were retrospective in the majority of the cases. So I'm not sure we can learn a lot of them, but we have a tendency. No study reported prevalence of mixed mitral regurgitation etiologies, functional, degenerative. We put mitral regurg, but we don't really know what's going on there. Several registries, including in France, showed the significant association between mitral regurgitation and 1-year mortality after TAVR. We know that the prevalence is high. It ranges from of severe MR and TAVR need. So aortic stenosis ranges between 2 and 33%, and it can go even to 50% if you include patients with low ejection fraction, low gradient. So they are a subgroup of patients that need this. So this slide is an invitation to discussion that we can have afterwards. One of the topics where I think we should not leave mitral regurgitation after a TAVR is the patients who have patient prosthesis mismatch, because these patients will have a residual gradient across the aortic valve, and this has been shown to be associated with higher mortality and lesser regurgitant volume recovery. So that means patients who have higher gradients are unlikely to improve their mitral regurgitation. The management strategy of patients with severe aortic stenosis and concomitant moderate and severe MR depends on a number of factors. The operative risk that has to be evaluated, and I think this is why heart team is very important for that. The mitral regurg severity, but also the anatomy leading to that, and the etiology, as I've said, which could or not lead us potentially to estimate the likelihood of improvement. The key to decision-making in evaluating MR etiology and severe severity, by a good echocardiography. I know that Edwin is leading this in Montefiore, and I think probably he can comment on this later on. I think this is also a key. It's not only by putting numbers that we can improve things. So for the tricuspid, quickly, I just selected this topic, but there are many papers on that. Concurrent significant tricuspid regurgitation is definitely associated with approximately 2-fold increase in both early and midterm mortality in patients who have aortic stenosis. And I mean, it makes no doubt to anyone, and we have learned this from surgery also, that leaving a moderate or severe tricuspid regurg after mitral surgery is not a good thing. So we definitely need to tackle this problem. And that's why we want to show you 3 cases quickly. The first one is really has been recorded last week. for China Structural Week, but we thought it's very important to share with you. Can I continue, Azim?
Absolutely, that's great. Please.
So the case, it's a man with a complex anatomy. So we selected this because it was also a polyvalvulopathy. As you can see, it's quite young, but he have a lot of comorbidities with severe COPD, severe arteritis. So we will see the CT, and so the femoral access is not a possibility for him. So we choose a carotid, like you say before. Also, the severe scoliosis contraindicating the transeptal puncture, like a classic transeptal puncture. And you have also a mitral calcification who makes this case like not an easy case for mitral clip. So on the echography evaluation, you have a normal left ventricle function. There is a aortic stenosis. There is also a severe mitral regurgitation, organic severe regurgitation by prolapse, P2 prolapse, and there is also an increase of the pulmonary pressure. So in details, it's like a palliative case with a lot of contraindication. And when you see the details, there is also a severe, very severe coronary stenosis on the right coronary. So there is a three procedure option. Here we have the venous access. We discovered during the live that there is no classic inferior vena cava. So for us, it was a little tortuous to find the good access for the mitral clip device. So as you can see, we find a way in this very complex anatomy. So it was clearly not an easy case. And at the beginning, Thomas and Lionel say to the different colleagues that maybe at the end, maybe we don't succeed because it was a very tough case selected this for this complex session. So here we are. So we have the coronary at the beginning. As you can see, we have the introduction in the right part. We are also the safari wire by carotid access. And here we have the CT. So as you can see, there is a big aortic aneurysm with a very large thrombosis charge. And there is also a very severe arteritis. So as you can see, the femoral access for TAVI is not mandatory. The pulmonary and the scoliosis was very severe, and so the presentation of the patient was very atypic. Here is the femoral access, very small, and the annulus is around 24 of diameter. So we manage Edwards Sapien 26. So with Azurion Philips we can do the phantom of the valve to have the good selection. So what do you think in the panel? Would you begin with that? The coronary PCI, the mitral approach, or you begin with the TAVI procedure? What is your first move if you do a combo procedure?
Wow, that's super complex. The typical Thomas Modene case. No, yeah, I think there's I think there are a couple of different ways you can do it. I must admit, in the past we would always do the coronary first before the TAVI. We don't do that. I don't do that all the time anymore. Sometimes if I think the AS is very bad, I will do the aortic valve and just get it out of the way so that the PCI is just a little bit easier, because if you have very bad AS and you have to do rote wherever, you can run into issues. But I think in this case, the PCI doesn't look super complex. So, I think stent the RCA, then the TAVI maybe next. But I can't wait to see how you got up to the mitral with an anatomy. That's like ridiculous.
You're right.
Anatomy.
Yeah, you're right. The main thing that's the left ventricle, it's have a good function, and the PCI is not so complex as you can say. So we begin with the PCI. So it's a good sense to begin with the PCI, and so we have a good result with this approach. So it's a radial approach for the PCI. And so after this, we can begin the carotid approach. You have the camera on the Thomas carotid scarf, and so you see that it's quite easy. So it's a forehand procedure, like a femoral procedure, and it was the only way to go for this patient. Here you can see little tips. Sometimes when you go to the carotid approach, the balloon can be not exactly on the valve, so you have to retract on the catheter. That's a little tips and tricks, because you don't have the possibility with the device like in transfemoral.
So you can see it. I mean, you can use the commander catheter, but you could use also the certitude one.
Okay.
So you just have to be careful that with this surgical access catheter, the balloon is already positioned.
Right.
And you have to be sure that it doesn't move up and down.
Okay. Tomas, so I mean, so many people are doing transcarotid now. It's really become very popular in the United States, thanks to you. Do you think it's ever going to be done percutaneously, or you think it will always be done with open access?
Listen, it can be done. To be honest with you, it really can be done. My question is there any advantage of doing this, honestly, because it's a quick and easy.
Right.
But this is the only thing.
Okay.
This is because, I mean, let me tell you, the reason why we don't want to do it is to avoid any complications. But because you're in the cath lab, you can inject, you can put a stent, you can immediately find a bailout strategy in case you have a complication. It's doable percutaneously.
Yeah.
It's better than subclavian. We can do it together, Azim.
So here we have the final evaluation with the final injection. For the depth of implantation, it's a little different for the transfemoral. It's very sensitive, so you have to be very precautious, more than transfemoral access. And so the high was quite good, with around 3 millimeters of depth. There is no conduction disorder, so we are a little lucky on this complex case. And so we can continue with the study of the mitral case. So as you can see, there is a prolapse, and there is when we do the X-plan, we see clearly the P2 prolapse, and with the consequences of the severe mitral regurgitation. You can notice also that it's a short anatomy, with the annulus looks not so large. So maybe in the mitral reflection, we have to take in consideration the gradient of post-procedural mitral procedure. Mm-hmm. So during the mitral evaluation, Thomas finished his aortic closing. So as you can see, the carotid approach there is no bleeding. It's a lot of control. And for the cardiac surgeons, the carotid approach is not a very hard way.
Yeah.
Okay.
Yeah, I mean, and it's a small incision. Again, you can do it under heparin. Didn't.
And do you always? I mean, you're doing a mitral clip as well, so you're under general anesthesia. But otherwise, do you do the carotids awake as well?
No, not. I mean, I know this has been done. We published on this, Azim. This can be done under local anesthesia, definitely.
Okay. And then,
I mean, our anesthetists don't want to, but they are very quick and they make it very light, so it's okay. Yeah. But it's doable.
There was a question in the chat just while we're on the carotid about, do you assess it with ultrasound, CT, or both? And what do you do if there's some carotid stenosis? What degree of stenosis would preclude this approach?
So there is, honestly, if there is a stenosis of the bifurcation, you can do both. You just treat the bifurcation first. Mm-hmm. And because the approach is not, the access is not the same. We are very low in the carotid. We are almost 1 or 2 centimeters above the aortic arch.
Oh, wow. Okay.
We are really very close.
Okay.
So this part of the carotid is almost always
healthy,
free of calcifications.
Yeah.
And if you have a carotid stenosis, you have to treat it in the same time.
Okay. So if you had a stenosis, you would do an endarterectomy?
Exactly.
and then do the TAVR through that
Absolutely.
access.
Yeah.
Okay.
And you are below, actually. You're not on the
Okay.
same side.
So in fact, the carotid stenosis is not a contraindication, but you have to be aware of the contralateral carotid access have to be very clean, because there is only this carotid who can make the perfusion, cerebral perfusion. And so we also have a special protocol with anesthesiologists to have high level of pressure during this special patient who have a contralateral carotid stenosis. You know what I mean? To optimize the cerebral perfusion during the procedure.
Okay, great. So take us through this mitral clip. I don't know how you got the transeptal here, but anyway.
Yeah, so we already do the transeptal, but as you can see.
But Azim, sorry, I mean, the tricky thing of this case is the calcifications on the the annulus of the leaflets.
Right.
So this is one of the discussions that we can have. Should we have done it like this or not?
Yeah.
But I mean, I'm sure you would have done the same thing. But this is also one of the things we can discuss.
Absolutely. So can you just explain a little bit, because I was confused, what was the problem with the venous access and the IVC? It didn't connect directly into the right atrium?
So this patient is a very short patient. He has this morphology body, I would say. He has, how do you say, the diaphragm are in the thorax.
Okay.
And the diaphragm, the diaphragm is compressing the inferior vena cava.
Oh, wow. Okay.
And it's generating a high pressure in the venous system, which explain why the veins were dilated at the level of the liver.
Okay.
And the kidneys.
Interesting.
Yeah, and it's very hard to anticipate, even with the CT, because we don't really find the inferior vena cava, and you know, sometimes even if you don't see quite clearly, in fact you find your way. But in this situation, it was very torturous.
Okay.
And Azim, I think we have not been discouraged, because we did in Bordeaux 10 cases of congenital mitral regurgitation, where we had always difficult venous access, and we always found a way to puncture them.
Okay.
That's what I'm saying. So I think this is going to be also a new indication for MitraClip in evolved congenital mitral regurgitation.
Yeah,
these patients have been operated 4, 5, 6 times.
Wow. Okay. So obviously your concern was whether, you're going to get a gradient or not with all that calcium in the annulus.
Yeah.
Right.
That's a big preoccupation. Yeah. So here we are on P2 and on the medial part, and so I advance a little quickly, but the thing was the posterior leaflet was not so long, and it rolled a little bit, so it was difficult to keep it the whole leaflet. But at the end, we have a first not so good results, but we have no more regurgitation on the lateral part. So we discussed all together, and we find that this, after some times from some try, this I think it was the third try, and it was for us the best result.
It looks really good
before the delivery.
Yeah.
And we've taken a small clip, of course. I mean, I don't know if you've discussed this. We've took an NTW. We wanted to go for one attempt, the larger bite that we could, but not the longest one because of the calcifications.
Right. Yeah, I would have avoided also an XTW. Yeah. Let me see if Dr. Ho wants to make any comments.
So we have read the gradient below the delivery of recenter on the orifice. So the gradient was not so high at this level, so we consider so it was just 2 of mean gradient. So we consider a two-clip strategy, even before the delivery. Okay, I just advance a little bit. Up. Okay. And look at the scopy, the position of the clip, it was not very used, you see. So it was very tricky anatomy. So all the repair, the classic repair, are not are trouble.
Yeah,
so
that's a very weird.
Yeah, it's very real.
Fluoroscopic picture.
Yeah. Well, we see each other. I say maybe it's wrong, but so we have to trust the echographic guy and the echography team and the echo imaging, because clearly in this situation, even if you don't have the classic scopy, your echo is your eyes.
Right.
So we deliver the system. Yeah, perfect. Up. I continue to advance a little bit. And so the final result was this.
Wow,
so with only one clip. Yeah.
That's a fantastic result. Congratulations. Wow.
Yeah, we make many tries, but I think this one was a good one. And so at the end, it was not so. At the beginning, we advanced with a lot of humility because we are not sure of the results. But at the end, we are really happy to share with you this. So it's possible to do a combo procedure with mitral and also aortic carotid access.
Yeah. Well, this wasn't just any combo procedure. This was one of the most complex combo procedures I saw. All right.
Okay, so we can continue with another.
Please.
Another case.
Absolutely.
So here we are.
Maybe let's just see if there were any specific questions about this case.
Sure. If someone have any question about the first case, do not hesitate.
Before we move on, was there any questions from the panel, from Andrea or Manafa, anybody about this case?
I have a question. Thank you so much for this great presentation. I was just wondering, when you guys perform this combo procedure in the setting of TAVR, PCI, and mitral repair with TEER, what's the rate of AKI in your center? Because I'm just thinking that, like, the risk of we're using some contrast plus the afterload mismatch with the mitral. Is there any evidence or data?
Though there is no, there's no data. That's what I'm saying. There are some topics from here and there relating the experience of a team, but there is no data supporting this. Coming to this patient, if you look, this was a very quick procedure. The coronary, Azim has been mentioning this, it is an easy stenosis that could be treated by direct stenting. So a small amount of injection. The TAVR procedure also, we always inject around, we use injections of 10 cc's, and we have the echo. So you reduce the amount of contrast you're injecting. For the mitral clip, you don't need contrast. But to respond directly to your question, I think this has to be discussed case by case. And you have to adapt the strategy to the needs of the patient. So reduce the amount of contrast, rely much more on echo, and I think you can make it.
I don't think we need a lot of contrast for this procedure.
No,
I think
for this one,
probably with this procedure you just showed me, 30, 40 cc's is enough.
Yeah, and if you look at the total time of scopy, 26 minutes.
That's phenomenal, because that's what was going to be my question was, you did this even as a live case, so you were probably talking more than usual. How long did the case take to do?
Honestly, 45, 50 minutes.
Wow, that's phenomenal.
Because, I tell you, the coronary access itself, honestly, me, it takes 5 minutes. Then the TAVR implant now, we can implant any TAVR in 15 minutes. And it's faster from the carotid space. The clip, it was 1 NTW clip. The longest phase was to do the transeptal puncture because of the anatomy of the patient.
Right.
The second case was a little longer. I have to leave. Sorry, but I'm sure that Thomas show you all the detail. It's
Okay.
this one. Yeah.
Okay.
So
Thank you, Guillaume.
it's a tricuspid procedure.
So this is a very interesting case that we did also.
Mm-hmm.
An evoke case actually. So the
Okay.
patient, we did it last week also. The patient came to us for a severe tricuspid regurgitation, and this patient was part of the TRISCEND-1 study.
Okay.
He was supposed to have a moderate mitral regurgitation. Okay.
Mm-hmm.
Yeah, I'm sorry, I didn't answer the question with regard after load mismatch. We can talk about this later.
We'll talk about it later. Yeah.
So, I mean, there is nothing special. I mean, Azim, you've done many of these cases anyway. So the guiding sheath first and the catheter you put in, you know, you have all these maneuvers, primary, secondary flex, to be sure that over the super stiff wire, to be sure that you're gonna go into the tricuspid valve.
Mm-hmm.
You're not gonna spend a lot of time on the technical part of it, as you can see it here. So I'm gonna move forward. Of course, we rely a bit more on the MPR echocardiography acquisitions for the tricuspid than we do it for mitral.
Right.
And then you start the deployment of the valve, as you can see. So you're going to uncover the valve and starting to liberate free the posts of the evoke valve. And you know, we have to be sure that these clips are below the tricuspid leaflets. So this is the most tricky part. You know this, I'm not gonna teach you anything here. So once you have started opening the clips, you do it at 20, 45, and 90 degrees. And then you're gonna just be sure that the valve is sitting in an orthogonal fashion in the annulus itself, which is not always easy. But this can be achieved by going septal lateral and moving a bit, I mean, using primary flex, secondary flex, which also means you can go anterior posterior. You just have to be sure that the valve is not tilting, as you can see it here. See, we want to be sure that the valve is opening below the hinge points of the leaflets attachment. And then you're gonna turn around the clips. As you can see it, we have a beautiful image here. You're just gonna turn and be sure that all of them are sitting nicely below the valve, but also against the annulus. And it ends up by deploying the valve very nicely also, with a good result, no regurg at the end. We're very happy with it. The problem is the valve was deployed, and we went to check the mitral valve again before leaving the room. And we discovered that the gap get larger, and the leak, which was moderate in the beginning, became severe, as you can see it here on the echo.
So probably you think it's just the increased cardiac output, Thomas? I mean, the forward stroke volume that's increased now?
Yeah, probably. To be honest, this is something that we have to discuss for all these patients from now on. But I agree with you. By eliminating the tricuspid regurg, you improve the filling of the left heart and you increase the output. And this is, the left ventricle is getting a bit larger. But what I don't explain, Azim, is the gap for us appear to be also larger. So the output is one thing, but the gap also was another thing.
It's interesting.
Yeah. So, I mean, it's okay. We said, okay, we have a gap. Let's treat it. And we did the transeptal puncture. We just exchanged a catheter by another one. And we went and we did the clip, as you can see it here. So we did the first one.
Oh, you got a gradient.
Yeah, but you will see it. It's interesting. In the beginning, it was 10. And then by fine-tuning the analysis, it went to 5, because you can see it. We still had a regurg. On the medial side. So we wanted to add one more, because I mean the mitral regurg is still more than moderate for us.
Okay.
Okay, and so we added the other. Of course, it was a bet because the gradient was already 5, but 5 having keeping in mind that we still had a significant mitral regurgitation. And actually, we put it exactly where we wanted to put it, which means where the remaining regurg was significant. As you can see it here.
Mm-hmm.
And this is, I'll show you the final result. Because we're gonna run out of time. We're gonna need some time to the discussion, of course.
It's interesting also to notice that sometimes the MPR utilizations can show us this very extreme treatment. By example, in this medial position, with the shadowing of the first clip, the MPR view for us, it's clearly the reference. And it's very hard to have a good appreciation of the mitral access without the MPR utilization. I don't know what is you believe, but
yeah, I mean, we now also use the 3D MPRs for most of the procedure.
Yeah. And Azim, I think you agree with me. The MPR is mostly used for regular cases when you approach the commissures.
Yeah.
Yeah.
It's very helpful when you're gonna go and grasp at the level of commissures. And you
Absolutely.
see, I mean, the final result, I mean, we can say that it was pretty satisfactory given the situation. I mean, look at the tethering of the leaflets we had before. So
that's a great result.
Yeah. So this is another demonstration why percutaneous therapy should also evolve and integrate more and more combo cases, not for the beauty of the combo cases, but because it's needed. Quickly, the last one, I will go very quickly here. It was a Tendyne case plus the TAVI. So we implanted the TAVI first. I'm not gonna show you. I mean, this was a regular Sapien 3 implant. And I mean, unlike other centers, we privilege femoral access. I personally hate to use the same transapical access because it doesn't go in the same direction, and I want to avoid any.
You don't want to pull on the apex.
Exactly.
Right.
Which could damage more muscles, cardiomyocytes.
Yeah.
It's a small incision. You don't need a rib retractor. So, I mean, you can see, or maybe you don't see it. So this is forced prolapse, the mitral leaflet, which was responsible for severe mitral regurgitation. So the TAVI was implanted, as you can see it here. We go quickly. There's nothing special here. Again, we rely a lot on Echo Navigator fusion images. This once you adopt this technique, I mean this technology, it renders your life much easier.
Yeah.
And transapical approach, nothing special. So here we use the 3D to have an idea about the maneuvers you're gonna do it, how you go lateral, how you go medial, or anterior, posterior. So you don't have to talk anymore. You just watch the screen, and you know what you are seeing, and the echo can guide you as you have been doing this yourself. You puncture the apex, you put the wire, you do the lily pop maneuver to be sure that you're not entangled with any cord, and then you enter with the catheter here, and then you deploy the valve. So you see, we're doing this with Lionel is my friend and co-leader of the interventional cardiology department here with me for structural work. You have to be sure this is a D-shaped valve. If you're not familiar with, you have to be sure that the anterior part is sitting between the two trigones, very parallel to the trigones. This is it, the cuff, in a way that when you open it, you see it. It's sitting nicely here.
Yeah.
Between the trigones, the two commissures also. Then I will accelerate because it's good to have some time to discussion. We have 8 minutes. the valve is implanted very quickly. You have to maintain it, you know. So
Mhm.
the tendine relies a lot on the tether and the pad, and it's not only relying for anchoring on the radial force. You really have to exert a mechanical pull to keep it in
To
position.
keep it in place, yeah.
So there is no paravalvular leak. There is no major concern with regard.
Mhm.
The valve is already in position, and we are putting the pad. You can see it here, and that's it. And this is the final echo result. It
Beautiful.
spouses nicely the annulus.
Mhm. And how long did it take? How long does it take to do a tendine?
Yeah, the tendine case is very easy, Azim.
Yeah.
Maybe half an hour.
Okay.
Half an hour. You know, the longest part of the tendine implant is when you do the fine tuning of the tether tension.
Yeah, the tension on the tether, I remember.
Yeah, because the Abbott people always come with no, this is too high, this is too low, and then it's a combination between paravalvular leak or not, LVOT obstruction or not.
Right.
So yeah, that's it. These are the three cases we wanted to show you, and that I think are important for all of us to discuss and see, I mean, with the group, how we can move forward with these new indications.
Yeah, that's phenomenal. I'm going to pass it on to all the fellows now. We have some questions for you. There's some questions in the chat. So just, one of the questions in the chat was, with that case of the evoke and the mitral clip, Dr. Manigas is asking, do we think that the evoke could have changed the anatomy and altered the shape of the mitral valve annulus? I think it's possible. We don't know, but it's definitely possible. I mean, it's a very rigid valve, right?
Yeah. It's a rigid valve, and the mitral and tricuspid annulus are not far from the one from the other. Probably.
Yeah, potentially. And then there's another question from one of our fellows, Pier Pasquale. He says, number one, any preference for right versus left carotid access?
No preference. You know, when I used to work in Lille, we used to do 100% using the left. Now I'm in Bordeaux, and we 100% is the right. No, and one of our papers that we reported, it seemed that it was faster, it was less bleeding from the right. Don't ask me why, but there's no significant difference. The only thing I can tell you is sometimes from the right, because of the innominate, you have more tortuosities, and you just have to be careful about how you put the how do you say, the pigtail in the one of the coronary sinuses because of these tortuosities. Otherwise, it's the same.
Okay, excellent. And then, when we had this case with multi-valve disease, when I worked with Alfieri, he always said to me, if you have multiple valves and you're going to treat them percutaneously, always start with the most distal valve and then work your way back. So start with aortic, then mitral, then tricuspid. I mean, what do you do when you have multiple valves? Which one do you do first?
First, I think when you have a mitral and aortic, by taking away the obstacle of the aortic, you give time to the mitral to adapt or the ventricle to adapt, probably. Right. And the analysis is different. Then speaking about mitral and tricuspid, honestly, I don't know. One of the questions I can ask you or ask Edwin about is, if we have the mitral first, would this make the echo acquisition more difficult, or vice versa? I'm not sure that in terms of clinical adaptation, it will be a difference between mitral and tricuspid. But definitely we start by the aortic when you have an aortic.
Right. When we do our combined mitral and tricuspids, we usually always start with the mitral first and get it out of the way, and then do the tricuspid. But I think, okay. I'm going to pass you on to all our fellows. You see how eager they are to ask you questions. Some of them you may know, but let's start with Andrea first. Andrea?
Hi, Thomas and Guilherme. It was nice to see you again. I have just one question for this combo procedures. If one of the procedure, let's say the aortic one, can be done transfemoral, so no need for general anesthesia, How does this impact on your decision algorithm? Because I mean, for mitral and tricuspid, it's much easier to do a combined. How do you do in these cases?
Yeah, it's a good question, but in fact, the local anesthesia we procedure in the surgical area, so the patients are sleeping, are not awake. So there is, in any case, there is anesthesiologist, even if it's a local approach with no general anesthesia. So that doesn't change a lot of things for us, and maybe you have more control on things if you do TAVI with a general anesthesiologist, if you go after on the mitral approach or tricuspid approach. So I think that doesn't change a lot of our reflection about if we are sure that we want to treat all in a combo procedure. You know what I mean? So if it's a carotid approach, that doesn't change if it's femoral approach. If you are pursued, that's the combo approach. It's a good one.
And you know, Andrea, I think this question also depends on the environment in which you work.
Yeah.
I mean, here we have full-time anesthetist and nurse anesthetists who are present in the room. We can switch at any time. Okay. And they don't leave the room. They make also, even if the patient is under general anesthesia, much more collaborative work. So you can rely more on filling, not using inotropes, all these minor things that can make your procedure faster and easier. Yeah, and I think this should be taken into consideration.
Absolutely. I think, you know, what you've done in Bordeaux as well, to really have the program truly a combined cardiac surgery, cardiology program is the biggest thing. Because yes, once it's a truly combined program, same budget, same everything, staff, same team, it gets rid of a lot of obstacles to this, because, you know, often the biggest challenge for us is anesthesia, getting enough anesthesia.
Yeah. To be honest with you, this is of a great comfort, really. Yeah. It honestly, it makes everything much easier. I mean, there is a negative thing in it, is that sometimes moving from a case to another is not as quick as you want it to be, but it makes you work in a much more secure environment. And I mean, honestly, we cannot complain, you know this. We can do 5-6 cases a day sometimes, and despite this.
Okay, excellent. Sebastian?
Yes, hi Azim. Hi Thomas and Guillaume. Great talk and well, excellent presentation, very nice cases. I have one question to you both, maybe. Can you try to define, I mean, when talking about aortic stenosis and mitral regurgitation, you said the numbers range from 33% to up to 50% having both mitral regurgitation and aortic stenosis. Can you try to define, you know, a group of patients that might benefit obviously from a combo procedure, and in which patients would you maybe first do TAVR, then reevaluate mitral regurgitation again, and you know, refer them for reevaluation in the 3 to 6 months maybe, or after that? What do you think? Is it only primary and secondary mitral regurgitation, or are there other factors you might include?
Sebastian, this is an excellent question, and this is exactly the topic on which we should collaborate and work together to get more powered studies. But I think a degenerative mitral regurgitation, which is associated to aortic valve stenosis, is unlikely to cover afterwards. I mean, the prolapse, the flail, the rupture cord will never disappear because you treated the aortic stenosis. So these are definitely a different category, which I think you try at least consider upfront, treating them at the same time. Functional are not the same, but functional also, it depends on what is the etiology of the functional, if there's any chance of reverse remodeling that could tell you that this patient is likely to recover. Practically, that's why the ranges are so large, between 2 and 33 up to 50. Right. They are so different from a patient to another, from a report to another, that you cannot say anything. And in this category of patients, I think we should, at this stage of knowledge, be very careful. Do the TAVR, evaluate, and see then how things can happen. Except if, like the case we showed you, it shows that there is how do we say, an increase in the mitral regurgitation amount, which like happened with the valve. But I mean, I think in these patients we have to be ready to adapt our strategy.
Yeah, absolutely. It's a great point. Thank you. Jonathan, Manaf, Faraj, any other questions before we let the team from Bordeaux go?
Don't let me go.
We'll never let you go.
Then good morning from my side, and I'll continue with a brief question. You mentioned Jonathan now joining in New York for a few months as well. Good morning. You mentioned your passion for innovation. So in this field of combo procedures, do you see a role for innovation there? 2 points maybe. There are these devices that do both, for example, cerclage with this TR add-on, but you also mentioned that you might get into problems when devices interact with each other, TMVR device plus TAVI device. Do you think there is a role for innovation there? What would this innovation have to address? And do you think it would be worth going into dedicated solutions here?
I mean, if you're asking me if I believe that there is a place in the future for devices that could already integrate the combo approach, the response is I don't see how, because all the devices we have today, we will have them in our hands for the coming 10, 15, 20 years. So there's nothing new. And there will be nothing new. I mean, Azim and myself, I think if we put us together, we're involved in all the innovations programs that are covering the earth. So this is the first response. If it's, we need to develop more skills, guidelines, and technical solutions to make it easy to be adopted and widely used, yes. And I think from this perspective, being able to predict which patient needs a concomitant and which could better benefit from staged is important. And for this, I think building algorithms, imaging guiding decision tools is definitely part of the future of innovation that we should work on. And of course, we should not forget, Azim, and you know that very well, that there are some other combo cases which are dedicated only to one disease. I would say annuloplasty plus neocode, for example, is part of the concomitant procedures that we'll be doing in the future.
Yeah, absolutely. So Edwin, I think, had a comment. So I'm going to let Edwin have a comment, and then Gali, we're coming to you.
Hi, Thomas. Thanks so much for joining and then showing us these great examples. I particularly like that one that you showed with the Evoke and the clip, because for sure, you know, we try our best to always predict what's going to happen, but you never know. So it's always nice to see sort of when you have that toolbox and you're able to respond to sort of changes throughout the case. I was really curious because, you know, you mentioned that you do have this, I guess, combined work program where you know, have CT surgery, cardiology, imaging, everything together. How has that changed your approach to actually training fellows and teaching? Do you also try to have that very integrated approach?
Yes. So, I mean, there is an obvious pathway. For example, Guillaume is not going to learn surgery, but he had a 6 months training in the surgical department, and he knows the unmet needs of surgery, and he knows a bit about this culture. He knows very well how to talk with the surgeons, but also with the anesthetist. And this is not an easy affair, you know this. The cardiac surgeons have the obligation in our unit also to have a training for structural valve disease. It's not only to learn how to do it and then leave and say to the cardiologist, I know how to do it, but I think because they need to integrate this in their future approach, in the modifications and the evolution of the indication. So I definitely believe that there is a problem of different way of thinking, which means what we call usually culture, but the only way to treat it is to put people together. And I mean, we still have the same debate sometimes, the glass half full or half empty, depending if you are a cardiac surgeon or cardiac interventional cardiologist, but at the end of the day, it works. What I like mostly in my team today is that the echo imaging have, how do you say, gain a huge importance, and they think like us. They recruit for us. They. I mean, sometimes they scrub and do cases with us, and I think this is a step forward.
Yeah, absolutely. Edwin, sorry.
No, I was going to say that's great to hear. Yeah, I completely agree with your comments. I think, there are challenges, but I think it really is the way forward. Thanks.
Thank you, Edwin.
Gali?
Thank you so much. That was really amazing. I have a question regarding TAVI and my Watchmen. So, do you recommend, like, I know it's been happening off label, but have you had any experience with TAVI and Watchmen concomitantly, as well as sleep and Watchmen or Evolute, and how do you see this being applied to the current era?
So, I mean, honestly, to be, we haven't done that many of these because the LAA closures are done by our congenital cardiologist here. And, but also, I mean, I don't know the question very well, but probably you can correct me. I mean, in the literature, we haven't shown a benefit to do this in the same case. This is what I can tell you about that. But I mean, eventually, if we show any benefit to do it in the same time, and this is what we do sometimes also surgically, I see no reason why not to do this. And it's technically it's not going to be very difficult to integrate. So two obstacles for us. We don't have the experience. We are not today convinced by the data telling us that we should do this in the same time. But if it ever happened to be the case, we will do it.
Yeah, there is a randomized study on the way. They're struggling to finish it. Samir Kapadi in Cleveland Clinic. They're doing it's called a Watch TAVA study, where they're randomizing patients to either TAVA alone or TAVA and Watchman. So when the data becomes available, we'll have some data at least to whether a combined procedure can reduce stroke in these patients. Okay. So I think it's an interesting question. Great. Thank you so much. Merci beaucoup. You guys were phenomenal as always. We're looking forward to having you in New York and joining the group and come to spend some time with us. And thank you both, and particularly you, Tamar, for your friendship and dedicating a morning to us and showing us some really innovative procedures. I mean, congratulations on everything you're building in Bordeaux. It's really phenomenal to see how successful the program is.
Thank you, Azim. Thank you, all of you. We were very happy to share this hour with you. See you soon.